Hello everyone. I am at Dr. London's office where I'm going to get my monthly eye exam. As you know, I've had type 1 for 50 years. I have some issues, retinopathy, macular edema, and I'm going to show you how a typical visit goes. And we're going to learn something about diabetic eye disease.
Good afternoon. Are you here to see Dr. London?
Yes, ma'am. My monthly visit. Can't wait. This is the ocular CAT scan. They take a cross-section of your retina and your macula, and they look for swelling. And we'll take a look when we see Dr. London. Yeah, this is the left macula, which is important for central vision. And you can see that this part looks pretty normal, but then this part, you can see it goes up with a lot of cystic swelling. And so all the injections I get are meant to reduce that swelling. Now it's time of my visit at the eye doctor's office to introduce Nick London, who's been my ophthalmologist, my eye doctor for several years, and I could say has saved my vision. So Nick, say hello to everybody. Tell us a little bit about your background.
So Steve, first of all, it's awesome of you to come into my clinic and invite me to do this. It's really an honor. You know, you're probably my favorite patient, if not one of the very top 5. Yeah. So about myself, I grew up in all over the place. I was born in the Bay Area. I moved to Ohio when I was about 8. I went through high school and then back to UCLA, and then hopped around for medical training. I went to Case Western Reserve in Cleveland, back to the Bay Area for residency, and then I went to Wills Eye Hospital for my retina fellowship, which is a 2-year retina fellowship after ophthalmology training, 2010 to 2012, and then got to come to San Diego.
For those of you that don't realize, Nick is a super specialist. There's all these different parts of the eye. The retina is the part that is affected by diabetes, high glucose, other things. Yeah. So I really appreciate you taking the time. I think the first thing is, let's talk about diabetic eye disease. Yeah. And don't get too technical on this. What is it? And to me, it's, the two main bodies are retinopathy and macular edema, both of which I have.
Yeah, so they're tied in together pretty closely. So diabetes, the main side effect of diabetes, or the consequence of prolonged diabetes in the eye, is vascular damage. And it's a microvasculopathy, meaning it affects the smallest blood vessels in the retina. So if you look at this picture here, I always use a lot of photos to kind of demonstrate things to my patient. And just to orient you, this is the retina. So we're looking at the very back wall of the eye. This is the optic nerve, which connects the eye to the brain. These are the main blood vessels coming out from the center of the optic nerve there. And then you can see them branching out. The retina is everything that's orange in the background. So the way I describe diabetes in the eye to my patients is that think of the blood vessels like a tree. You've got one main trunk, and then you've got branches into smaller and smaller and smaller blood vessels. Prolonged diabetes, prolonged hyperglycemia, or elevated blood sugars, affects the smallest blood vessels called capillaries. And you end up developing what's called diabetic retinopathy, where you get sort of, if you think of like the bark on the branches of the tree, you lose that shell on the outside of blood vessels. You end up getting little outpouchings of blood vessels we call aneurysms or microaneurysms in the retina. Those microaneurysms can burst and you can get bleeding, and you can actually see some evidence of that here. So these are little intraretinal hemorrhages, little spots of blood in the retina from ruptured microaneurysms. And you could get even more extensive damage. You can get loss of blood vessels. You can get whole areas of the blood vessels that actually will die. And we want to prevent that, and we can prevent that. And I think we'll get into that in a bit. But what you also alluded to is diabetic macular edema. So the macula is the center of the retina. So right here, the vessels kind of wrap around it. And if you get...
And that's important for vision.
That's the most important part for vision.
Macula.
Yeah, so that's your central vision. And so the macula there, the fovea there, this is your central vision. This is your bullseye central vision. So if you need to look at small details, the hairs on the back of your hand, you need a healthy fovea. If you have anything, even a millimeter of something going on in the fovea, it's going to have a huge impact on your vision. So In addition to the diabetic retinopathy, which is the bleeding and loss of blood vessels in the vascular tree, you can get leaky blood vessels, and that's where macular edema comes. Edema just is a fancy word for swelling, and macula is the anatomy there. So if you get increased inflammatory things in the eye from diabetic retinopathy, you get leakage from the blood vessels right in the center of the macula, and you can get swelling.
Let's take a look.
And
Yeah.
so we can see that here. And this is a very famous OCT of Dr. Edelman.
Yeah, we just got this in the other room.
So this is a cross section. So I know you can't see the pictures here well, but this is actually your retina in cross section. So if you took a line right through the middle of the macula there, and then looked at that under a microscope, this is more or less what you'd see. It uses laser light to produce this map of the retina, kind of like an MRI or something. So this is more or less, I'll use this bottom one here, that's more or less what a retina should look like. And as we get to the center, right in the middle of your macula, you can see these black spaces we call cystoid spaces or cysts. And those are little pockets of fluid, just like the cells of a sponge. If you were to look at a sponge in cross-section, little pockets of fluid. And you don't want that. That shouldn't be there.
So a normal eye, you would see something like this all the way across.
That's right. You'd actually see it all the way across. You have a little dip there called the fovea, no big deal, but you wouldn't see those cysts of fluid. So we treat that. So we treat diabetic macular edema, and we sometimes will treat diabetic retinopathy. And we have very successful treatments these days.
Yeah, now, as you know, Nick, when I first got diabetic eye disease a long time ago, they did laser therapy. They shot the different areas of my eyes with laser, and it killed the retina.
Yeah.
And that's, helped slow down things.
Yeah.
And nowadays, we do injections. So we might as well talk about the most common way you would treat retinopathy and macular edema, all in an effort to prevent the progression.
Right. So the big problem in any diabetic retinopathy and even macular edema is really ischemia. So that's loss of blood supply to the tissue, and the retina is very sensitive to that. If the retina starts losing blood supply, it starts releasing chemicals inside the eye that can be very toxic to the tissue, and it's a positive feedback cycle. You end up perpetuating all of these problems that we see. So we used to do laser to treat that, and we still do. Laser is still a very important part of what we do. It has not been completely replaced. It still is done. You can see an example of that in the photo here. So if I show you.
These little things right here?
Yeah,
Laser burns?
exactly. So this is just the central retina. The picture actually just goes in on the center part of the retina. It goes way beyond the edge of the frame here. But all these little circles are laser spots. And essentially what the laser does is we used to call it sort of killing dying tissue. So that tissue that's producing these chemicals that are bad, you treat it with laser, it creates a burn, and that's a permanent little scar there, which kills that tissue and decreases those chemicals from being produced.
Yeah.
We even used to do it in the macula. We don't do that as often anymore. These are little laser spots. And that's a little less clear exactly how that helped, but it leaves scars in the macula. We don't do that very much. The main problem is, again, ischemia. Ischemia causes chemicals, the main chemical being something called vascular endothelial growth factor. Fancy name. We call it VEGF. So VEGF also is very treatable now with injections. We have what are called antibodies that we can inject into the eye, very potent medicines.
Yeah, and I can point out, here's one that I've received, Eylea, Lucentis. There's 2 or 3 now, correct?
That's right. So there are 3 that we have available. Those are our 2 FDA-approved medications.
Yeah, and I've gotten injections monthly for 2 years, and now it's being spaced out more. And I also have patients that have brand new mild retinopathy. I've sent to you, and you get those treatments early. It's amazing how fast the retinopathy dissipates.
It's unbelievable. You can actually turn back time. We now have FDA approval to treat just the retinopathy. We didn't used to. And we can see hemorrhages melt away by inhibiting that chemical. You can see those little spots of blood over time just melt away. And it's like turning back the clock on damage, which is just, I think it's miraculous. And we've got things that are upcoming that are going to be even better.
Like what?
Well, we're involved in a lot of clinical trials here. So we do a ton of cutting edge research. And one of the things I'm most excited about that we're actually enrolling in now is gene therapy. So these drugs I need to inject into the eye.
Like Jordache genes, or
like Jordache genes, like your DNA. So we can. There's a couple companies that are working on this, but the one we're working with now is Regenix Bio, and they actually can engineer the tissue of the eye to produce Lucentis, which is one of the drugs that you pointed out. Essentially Lucentis. And so if you think about it, so I'm injecting these drugs in the eye, but If you're producing it already, you may not need injections, or you may need much fewer injections. It's not a cure.
But also the continuous release may work really well too.
As you know, with hyperglycemia and blood sugar control.
Yeah. Well, let me ask you, what is the best, and this is a really important question for the people viewing this, what's the best way to prevent retinopathy in the first place? Diabetic eye disease?
Yeah.
Because they're really closely related, as you said, retinopathy and macular edema. And if you have it, reduce the progression of it. I think it's pretty simple.
Yeah.
Find a guy like you and go to a lot.
Well, happy to do my best to help. But, you know, the most important factors in determining the risk for diabetic retinopathy and macular edema is the duration of disease. That's number one. So the people that have had diabetes for 20 years almost
50.
always have some retinopathy.
Yeah.
It's hard to get away with zero. I've seen it, but it's tough. In addition to duration is glycemic control, so your hemoglobin A1C, and something you've taught me recently, your time in range. So those people with continuous glucose monitors.
Hold on. An ophthalmologist talking about time and range. That's impressive.
Hey, I've got a wonderful teacher. So you know, those are the most important things. And then any what we call comorbidities. So you can't be a smoker. You can't have a sedentary lifestyle. You have to have a fairly healthy diet, of course, as you know.
And blood pressure.
And blood pressure is very important. And then regular checkups. So a lot of people don't realize that the data on compliance with seeing an eye doctor once a year if you're a patient with diabetes is not great from what I've seen. So even if you have no vision loss, you need to get in because these changes are completely asymptomatic until they're a problem, and you can prevent that. You don't want that.
Yeah, and I think that's a point that needs emphasizing. These early changes that warrant early therapy, there's no symptoms. So, I mean, you have to get a dilated eye exam by someone that knows what they're doing in the retina. And does every person need to see a retinologist like yourself?
No. So you start off with sort of a well-educated optometrist or comprehensive ophthalmologist. Both of those are fine. You want somebody that's going to either take a really good photo of your eye or going to actually physically look in the eye with a dilated eye exam. That's critical. You need that once a year, and they need to have a fairly low threshold for getting you to somebody like me, a retina specialist, with any sign of either of those two problems. We as retina specialists, we do not follow mild diabetic retinopathy. We typically follow people at risk of vision loss, either with active macular edema or with severe, what we call diabetic retinopathy, where it looks like you may progress to actually starting to bleed inside the eye, getting a detached retina, severe risk of vision loss without treatment.
Yeah, and I have my own answer to that question. You know, I think there's enough doctors out there that are really good that are not retinologists, but there's, you know, I wouldn't trust my eye to anybody other than someone that specializes in the retina. That's me. That's my suggestion because it's your eyes, and if something gets missed, you know,
I don't fault you. And one thing that's always good to do that I think is never a bad idea. You can visit one once. You can have them take a look and sort of give you an idea of where you stand. And I can, if I saw somebody and they were extremely mild and I knew I had confidence in an eye doctor in town, I'd say, hey, so-and-so is really good. They can follow you. But if, I have never, ever denied somebody that wanted to follow with me because I'm not going to miss anything. The buck stops here. I will protect your eye like it's my own.
Like you have. Well, is it time for my regular injection so I can maintain that improvement I have and maybe reduce it over time?
Let's do it.
Okay.
So the first thing I'm going to do is put a drop of numbing medicine in the eye. Look all the way up. So this is just a topical anesthetic, and this makes it a little easier. Good. Close your eye. This is a numbing swab. Look down. Good. And I'll just use my thumb to lift your lid up and just put this there for a second or two.
That's right where you're going to inject.
That's right where I'm going to inject. You got it. And then we do a tiny bit of numbing medicine right underneath the skin of the eye called the conjunctiva. I have you look down. Good. And just a little bit right there. Good. And so we create what's called a little bit of a bleb, which is just a little numbing medicine that's going to soak into the tissue. I don't typically use these, but for you, we're going to. Just some people, we want to keep the lids out of the way.
Okay.
So the most important thing with an injections in general are extremely safe, very, very safe. But we want to avoid infection. That's sort of like our nightmare is sort of getting an infection. It's about 1 in 5,000 injections, but we go to great lengths to avoid that. That and discomfort. So I'm going to have you look down. We're going to just gently put this under the lids, and this is just a little, look up, a little wire clip. If you've seen a Clockwork Orange, you know exactly what this looks like. I'm going to have you look down to this shoulder. Perfect. And I want you to stay right there and not speak. I love that we're both wearing masks right now because, again, we want to avoid a chance of infection. The last thing that we're going to do right before the injection is a drop of what we call betadine. It's a little povidone iodine solution. So look all the way down. I'm just going to put this right there. Good. And I want you to not speak. As long as you're looking down, you're good. Good. And then look down. Perfect. Right there. All right. How was that?
That was good.
Any pain?
No.
Perfect.
No. I would say each time is not that much easier than the last, just the mental part of it.
Yeah.
Sitting here, getting injected, but yeah, it's nice to go to someone with good technique. Well, I appreciate that.
You're welcome. I'll do my best.
I'll see you next month.
Very good.
Okay.
Good to see you.
Do the COVID handshake.
That's right.
So long, everybody. Don't miss your eye appointment.
Thanks, everybody.